Um, Let me try to get this straight. So I'm Gerald Major, and I'm the president of the Canadian Spondylitis Association. I love Calgary. Lots of friendly people here, so I'm going to hopefully get this to be a little bit participative, if you don't mind. So let's start doing some raise of hands. Raise of hands if you're here for ankylosing spondylitis. Okay, and raise your hand if you're here for psoriatic arthritis. Okay, and some people have raised their hand for both. Anyone challenged or struggled by any type of comorbidity? Anyone know what comorbidity means? Okay, we're going to get to it in the slide, but it's basically more than two diseases. So, I mean, a comorbidity of psoriatic arthritis is psoriasis, and you end up maybe iritis. You've got some gut stuff going on for probably many of us. So the fact that you don't know, I mean, it's kind of, a lot of people kind of don't know. So hopefully this is going to give some meaning to that. My story is I've been diagnosed with both AS and PSA, and I've got quite a few comorbidities. I've also had 7 surgeries in the last 7 years. So I've got both knees replaced and lots of foot and ankle work. Another comorbidity, osteoporosis I have, so I broke my hip. But the hip didn't have arthritis, so they just pinned it. Hopefully it doesn't get arthritis. But I left work about 6 years ago. I used to work for Citibank, and I did hedge fund services for North America, so a pretty busy job, and this condition took me out of work eventually. What took me out, as bad as my body was, is mentally. I broke down, so probably mental health and mood disorders. If it's not in your life right now, it probably will be at some point in time, and hopefully we can bring awareness to that and some ways and tools to manage it. So, general notes. You all have questions on blue papers, so when you get your question ready, we actually have an extended period of time this time for questions and a panel. It's going to be fantastic. It's going to allow you to ask your questions about specific things that you want to know about, and we have an excellent panel of experts here that can probably answer all of them with beneficial information for you. The evaluation form, if you can, that helps us get better. So that's on your orange sheet. The video will be available within 30 days and probably quite a bit sooner than that on the CSA website. And if you have your mobile phones, please mute them. I've done that myself. And we have quite a few, we have a lot of time to get into a lot of stuff, so hopefully it's valuable to you. So we've partnered with SPARC, which is the Spondyloarthritis Research Consortium of Canada. I was with them yesterday. Basically, they are your rheumatologists and researchers across the country that get together and research and study spondyloarthritis and try to improve our outcomes. So you'll hear from a few of them today that are in your area. And we also partner with the Arthritis Society to promote the event, which they've done successfully. I thought it was important to mention SPARC. It's a partnership that we have at the CSA. We're an extension of their business. And it's valuable to know the people that are looking exclusively at our illness and working towards solutions. Without any of our sponsors, this could not happen. So thank you for sponsors. There's a few of you in the room. Thank you for the work that you do, the partnerships that we have, and the help that you provide. So you may like this slide. Spondyloarthritis, you think it's hard to pronounce? Try living with it. Anyone feel that message? No hands? No one? Yes? Okay, perfect. By the way, how many people are actually registered with the Canadian Spondylitis Association online. Okay, not bad, but please, before you go, I've got business cards, you have material, you've got the AS guidebook sitting in front of you. Please pick one of those up, and there's many at the back if you need more for friends and family, etc. We have just completed first round's review of the psoriatic arthritis guidebook, so that'll be available next. And both, I mean, you can access the AS guidebook online, and as soon as the PSA guidebook's done, it'll be there as well. So these are the different types of arthritis that make up spondyloarthritis. The two top ones are the ones we're going to talk about today, but juvenile onset spondyloarthritis is pretty important to us. So we've done a great job in the past at looking at ankylosing spondylitis. We're starting to focus on psoriatic arthritis, and we'll move on to juvenile. I mean, that's our kids. Those are the ones that I heard yesterday that some of us that are born in the 70s, we kind of probably disease activity started before biologics. So for me, the 7 surgeries that I've had, that was damage that was done prior to biologics. So think about the kids, and if they have difficulty getting insurance coverage and plans and they can't get on this, then they're struggling at that young age, which is very challenging. So that'll be our next focus, and then we'll get to the rest. Any Facebook people in the crowd? Okay, I mean, I wasn't a Facebook person until I started doing this volunteer work, and I can see the value in it. If you're not a member, please sign up. It's worthwhile. It allows you to ask questions to people that are just like you, that have been down that road before, that have different experiences with different things. People talk everything from treatment options. I'm about to take this biologic. I've never done it before. Does anyone have an experience with it? I'm getting irritation at the injection site, et cetera, et cetera. I can't sleep at night. What kind of pillows do you use? Nutrition, diet, supplements. I mean, you learn the things that work from other people just by asking. This is an example of something. I mean, we work with international partners, so we take their material, we share it. This one specifically around the immune system. So lots of really good information online, a very active community, and if I can just ask one thing of people is, I mean, this organization is going to be as good as the people within it. So first of all, we need more. We have about 2,400 members right now. There's a lot more people than that in Canada living with spondyloarthritis. So my kind of theory from my background in the bank is I'd like to, and working with illness, I mean, you find out pretty quick that you have to work smart. So anytime we can copy and paste and work with partners and bring things in and use our community and our members to socialize and to answer questions and to give opinions on different things. I mean, the best way that this organization can run is if our members tell us what they want and what they need through Facebook conversations, through emails, etc., and then we start to provide. We work with our partners. We come up with solutions from you. I'm a big fan of, we should have probably 200 tools for people because every single person's going to like 6 different ones. And we need to really see, as far as living a new normal type life, we need different solutions for everyone. So please be active and participative, and let's really make a change and a difference to those like us. The one common thing that everyone comes to the CSA either through volunteer or to these meetings is that there's a burning desire to give back. I mean, we know what it's like to live with this condition. We know how it's impacted our lives. And for the most part, people don't want to see others go through that. So those are the types of conversations I have, and we can only get better together. Here's some of the things. So the CSA, I've just become the president in the last 4 months, and I really wasn't even in this, this healthcare sector until probably 2 years ago. So we've done quite a bit of transition. We have now 12 board members. Most of them are living with spondyloarthritis. We have a couple caregivers on our board, which is a very important part of our illness. And we're going to really make a big push to try to get content out there, to try to get engaged membership, to get more membership. We have students from different universities looking at awareness campaigns for us, trying to find solutions. And we're in the middle right now of enhancing our vision. Our vision really, I'll get to it later, but we're really looking at and challenging who do we need to be an advocate for, and it's really more than just patients. We also have an executive director. So if you run a non-for-profit all by volunteers, especially with this illness, you know that we flare at different times. So a lot of times we flare at the same time because there's difference in weather patterns, etc. So just because the volunteers within the organization shut down, there's no reason that the organization should pause. So for the first time, we actually have a paid person without spondyloarthritis that can help keep things moving forward. And we have a volunteer group to support social media presence and local support groups and events. So I think there's about 6 people now that we have on communications team, and 2 of them are professional social media people. So we're going to push out on social media, hoping for more engagement, hoping for more awareness, and a lot more content. As I mentioned, here's our vision to be the primary resource for people diagnosed and living with spondyloarthritis in Canada, and mission is to create awareness of spondyloarthritis in order to ease the path to diagnosis. So that's the one right now that we're challenging, and I think we can do more with allied health and extended care professionals. We can do quite a bit more with SPARC as far as being a voice for them. Part of our, so this is the question. So for those of you that didn't know what comorbidity means, I mean, you're like me when I was getting diagnosed and it was a long time to diagnosis, and then I didn't pay attention to what comorbidities were. So for example, when my eye flared, I started thinking that there was a contact in there, and I was digging it out for 2 weeks. Then I finally ended up at an eye specialist, and they called me crazy and said, you have rip-roaring iritis, and next thing you know, I was sitting there getting needles in my eye to relieve the pressure. So comorbidities are important. I mean, we're going to launch our awareness campaign around it, and what we're going to do is try to work with other patient organizations within our community and co-brand newsletters monthly that address all the different things that shouldn't be unaware to you and shouldn't come up and bite you as you're going through them. I found out about mental illness the day I left work and haven't gone back. So comorbidities, I often talk to a lot of people with spondyloarthritis, and what happens is you start to get into a situation where you've got 5 or 6. So for me, let's just go to, okay, so it seems to me that spondyloarthritis patients seem to have a lot more other things going on. And so we're waiting to validate that. But patients with spondyloarthritis are at risk, or at increased risk of developing certain comorbidities. And here's just a few. So my personal list stops around, I think IBD for me maybe is borderline. I think there's something there, but it probably hasn't shown because I've been on treatment. Otherwise, up until osteoporosis, those are all mine. And then there's a whole bunch more to watch out for. So I think we have to increase education around comorbidities. We have, why take an illness that takes 7 to 10 years to diagnose and then compound that every single time with a new comorbidity? So we're going to do a lot of community outreach on that, so stay tuned. Here's the community that we work with. So I look at research, and that's really our partnership with SPARC. Not only do I represent the CSA, but I also sit on the board of directors and represent the consumer group for the Arthritis Alliance of Canada, and that's a national organization of rheumatologists, researchers, allied health that all get together to try to make a difference in arthritis. We work very well with our medical industry, pharmaceuticals primarily, and great two-way relationships that really aren't, I mean, we propose programs, we ask our membership, we find out what we want to do, we propose with pharma, they either fund things or they don't, but the content is ours and the message is ours and they help to facilitate it. And then the other group that really there's a lot of work is patients, caregivers, and I would put patient groups in there. So not only is there the CSA, there's another 3 or 4 organizations that look at arthritis, none that specifically look at spondyloarthritis, so we're a little bit different there. But then you've got other patient groups from the Arthritis Society to HIV, I mean, there's groups for blindness, there's, I mean, every different disease that you can think of, there's a patient group for. This is where the comorbidities come in. If we can partner with someone that does, why would we go through and try to build content on psoriasis on one of our comorbidities when there's a psoriasis group out there? So those are the partnerships that we're looking to form, and I'm hoping that's going to change the way that we all work together a little bit more efficiently and better. So there's an opportunity there to share membership. If you need psoriasis information because that's your comorbidity, then go to this place and we'll house the information on our website for you. Some of the things that we do, this is an information session. We're going to get into webinars pretty soon on hot topics that are out there. We still do peer mentoring one-on-one in groups. If you want my card on the way out, I still talk to every person that comes in through email to me. We do newsletters, website, Facebook's great, Twitter if you're on it, and local support groups. So you'll see some signs around. We have 2 board members in Calgary that you probably met on your way in. If you didn't, Sarah and JR. So these guys are 2 brand new board members to the CSA, both living with both living with AS and some other stuff, and very, very active. So all of these signs around here that say Calgary Support Group, please take an interest. It's a great way to get out and just socialize with others that are going through things. I've gone to a bunch of them in the Toronto area, and I mean, sometimes they just end up being social gatherings. And it's a great way for caregivers and those suffering with spondyloarthritis to kind of connect and learn more about different things. So, what is that?
So this is the sign-up sheet for information.
Right.
We're just getting it started, so these are your time.
So these guys need help getting this thing off the ground. So hopefully, if you're interested, please sign up if you haven't already on your way out. Take note, take a picture of the thing, and what we'll do is we'll start circulating information about what the CSA has been up to. So you go to these support groups and get a 5 or 10 minute update on where we are, and then if you have questions within those groups, then they'll funnel back to us. We'll get answers and build programs around it. The other things we do, I mean, we help in the wider kind of coalition alliance perspective. We help, we do submissions around medication. We make sure that medication is getting to the right people at the right time. Navigating the system, I mean, I'm still navigating that system, so we get involved there. We help to shape policy, specialized care, and our awareness walks. So anything that comes into the info@spondylitis email group, or mine if you take my card, and you have special requirements in certain provinces, then we try to source the people that can provide you help, and then we capture that and put it on our website for content. Here's the group that you're gonna that you're gonna hear from today. Dr. Diane Mosier, Dr. Olga Ziozina, and Carolyn Johns is a physiotherapist. Alexandra Charlton is a clinic pharmacist, a very special person I didn't know existed. And we have a patient speaker that's going to talk to you about living with ankylosing spondylitis. So in a nutshell, I mean, it's a big puzzle. Everyone's different. Piece by piece, our commitment is we're going to help you put it all together. So let's talk about the stuff that you get from your appointment, blood work, x-rays, medications, etc. You all know that you don't have time to ask on different things, but there are a lot of different alternative therapies that are out there, and we're committing to help you through and navigate those. The value of partnership between the Canadian Spondylitis Society and Association and SPARC is really, we work together to help improve the outcomes of patients. So participation from you also helps continue this circle and making things better for people. This is where you can reach us, and we'll move on to Dr. Mosier. So try to figure this one out. I don't have a bio for you, but all I know is that fantastic person, great at what she does, and I mean, you're fortunate to have her in Calgary here.
Thank you.
This is forward, back.
And I'm also short, so I don't know how I'm doing this. Okay, so we need to close this one out. I think this is me. Uh-oh.
Ooh.
Something's updating.
You just have to close out of that.
Perfect.
And this is forward. Once I had to give a talk to the Canadian Bar Association, and the computer decided to update the during the talk, so I couldn't go forward with my slides. So they
Do not press that.
okay. So they told me I had to tell jokes until the until it was rather intimidating. So spondylitis is what ankylosing spondylitis is specifically what I'm going to talk about. When we decided to have this event here, not realizing that Saturday morning every kid in Calgary is coming for hockey, was the thought about, you know, really focusing on ability, not on disability. And so how do we get there? How do we get to preventing this disease or preventing the outcomes of this disease? And that's really what I'm going to focus on, and it really is about early diagnosis. That's an issue for us, which I'll address. Early diagnosis and early treatment will make a difference. And so that's really what I'm going to focus on in some of the recent research that's come out and some of the important information. As Gerald said, that we had the SPARC meeting here, which was all of the Canadian investigators over the last 2 days. So I'm a lot smarter than I was 2 days ago and can tell you a lot more. So, well, I think we talked about what a spondyloarthritis is, and I was corrected as well. We used to call it spondyloarthropathy, but internationally it's spondyloarthritis to really emphasize the fact that there's inflammation, redness, heat, pain, swelling is what inflammation is. And so there's a spectrum of diseases, which include ankylosing spondylitis, psoriatic arthritis, reactive arthritis. And reactive arthritis is if you, sometimes when people get food poisoning, Salmonella, Shigella, Yersinia, or chlamydia infection, it can lead to reactive arthritis in people who are genetically susceptible, which carry the HLA-B27 gene. That there was a huge outbreak of Salmonella when the Pope came to visit in the late 1980s because all the policemen were fed chicken salad sandwiches that were not refrigerated from Montreal. And so that was really, it gave us a lot of information about this reactive arthritis. It can be related to bowel disease, and we know that about 20% of arthritis that occurs in children is due to diseases like ankylosing spondylitis, which present at that young age. So really, this is a diagram that I often draw in clinic, and you can see that often people don't have one, they don't fit into one category. It's not all ankylosing spondylitis. You may have ankylosing spondylitis, and you may have IBD, inflammatory bowel disease, or you may have psoriasis and ankylosing spondylitis, or reactive arthritis and ankylosing spondylitis. And the UPA means undifferentiated, means you don't fit into any nice little box, that it's sort of a spondyloarthropathy, but we're not sure quite what it is. So the first problem is, how do we diagnose ankylosing spondylitis, and how do we diagnose it early? The back pain is huge in our population. 4 to 5 adults have back pain. So it's a bit like the needle in the haystack. How do we find those 0.5% of the population with ANK-SPOND, or 5% of the people with chronic back pain who actually have ankylosing spondylitis? We know that on average it's 8 years before people are diagnosed, and in women it's even longer because they often don't, for several reasons. One is that family doctors think that only men get ankylosing spondylitis, and the other reason is that women often present differently. The diagnosis used to require an X-ray changes, and the X-ray changes take 10 years before you sometimes see X-ray changes, so that's a problem. And the other reason is that, well, we want to diagnose early because we actually know that new therapies reduce pain and disability, and there's actually new work which I'll present that show that it prevents the X-ray progressions. So what's different between regular back pain and spondyloarthritis? And that the pain usually persists for more than 3 months. The onset is usually before the age of 35, but not always. That sometimes with inflammatory bowel disease, it's in your 40s that you may be presenting with inflammatory back pain. In the morning, your prolonged stiffness in the morning, usually greater than 30 minutes. And unlike everybody else, you feel better when you move and exercise, whereas most people with back pain feel worse when they're exercising, they're doing activities. I put this slide up because in addition to the inflammatory back pain, often people describe alternating buttock pain, waking up in the second half of the night with pain and having to get up and move. Enthesitis, I wanted to mention, is where the tendon inserts into bone, and that's particularly important in ankylosing spondylitis. Dactylitis occurs more with psoriatic arthritis, which is when the whole digit swells up, and Dr. Zuzina is going to talk more about that than me. The uveitis, but I wanted to talk about family history because when we're trying to find patients with back pain, and is this really ankylosing spondylitis or spondyloarthritis, one of the important things is there a family history of inflammatory bowel disease, ankylosing spondylitis, uveitis, psoriasis, because we know that these conditions have genetic, there's a lot of your genes really influence whether you get this disease or not, unlike many other diseases, and I'll explain that a bit in a minute. So that the family history is really important to take, and that really influences whether you think someone has ankylosing spondylitis or not. So this is just showing the pelvis, and these are the sacroiliac joints in here. And to make a diagnosis of ankylosing spondylitis, we want to see that there's disease in these sacroiliac joints. The ankylosing spondylitis can affect the rest of the spine, but it almost always begins in the sacroiliac joints. When we look at extra-articular features, we talk about psoriasis, inflammatory bowel disease, but with ankylosing spondylitis, uveitis is very common in 25 to 30%. We learned yesterday that uveitis is the third most common reason why patients lose their vision in Canada. So it's really important that people recognize when they're having symptoms, that they're seen quickly. And it's usually a red, painful eye, extremely sensitive to light. And it can occur in one eye at a time. It can occur in one eye and then the other eye. And Dr. Zuzina actually works in the clinic with our ophthalmologists who see patients regularly with uveitis and help work out what's actually occurring. So if you have those symptoms, then you should go to your family doctor, optometrist, or emergency room to be quickly diagnosed and treated. I mentioned about enthesitis. So enthesitis is where tendon inserts into bone. This is showing the whole complex, but it really, the in ankylosing spondylitis and spondyloarthropathies, that's really where the disease is occurring, is where the tendon inserts into bone, then involving the joints. And therefore, the inflammation is occurring at that area. That may be some of how this whole disease gets started, and I'll explain that. I was told to talk about why do we get ankylosing spondylitis. So this is a very complicated slide, which talks about, which when I talked to you, I said that, there was chlamydia and Salmonella Shigella. Bacteria seem to be able to trigger some patients with these diseases who are genetically predisposed. So some thoughts are, is there a bug causing ankylosing spondylitis that we have not yet found? Some people think that might be Klebsiella. But also there's research going into, is it related to the microbiome? The microbiome is all of those bugs that grow up with us. So we have millions and millions of bugs that are inside our stomach, inside of our mouth, that are part and parcel of us, and we live happily together most of the time. But there's a lot of research going on now, and at University of Calgary in particular, there's a real emphasis on this, and understanding what our microbiome is, what's inside of us, and how that might influence disease, particularly developing chronic inflammatory diseases. The thoughts there are actually, can you change things ultimately with probiotics by changing what bugs live inside of us? We actually know, and there's been some work done, that when people have chronic Clostridia infections in their bowel, that they've actually done fecal transplants, and it's been effective. So this is a whole area of interest, is our own microbiome. So is it somehow those bacteria being recognized by our immune system when they shouldn't be, because we should be living happily together? And that's triggering this whole immune complex that happens and leads to the disease itself. All of this pathway that's being worked out also are potential targets for therapy. So one of the thing that I want to point out here is when we think about what might be causing our diseases, that mechanical stress, so where you have that heel pain and the inflammation beginning there in a genetically susceptible host, is that helping to lead to the disease? Is it the microbiome that's helping initiate this? But what's really important are the genetic makeup, the HLA-B27. So this is a gene that's found in 90% of patients with ankylosing spondylitis, but it's also found in about 10% of the regular population. So it's not diagnostic by itself. But we do know that the genetic makeup of people with spondylitis is very important. I told you if there's a family history, that's very important in trying to figure out if someone has this disease or not. That then we have something that's triggering it. We have you're genetically susceptible to get these. And then what's been figured out lately is the pathway that's driven is something called IL-23, that it triggers the immune cells producing IL-17, TNF, and IL-22 that works on bone destruction, inflammation, and new bone formation. So IL-22 producing new bone formation. That's what's different in ankylosing spondylitis and psoriasis, is you get new bones, and that's why you fuse your spine. So back to diagnosis. Previously, the New York criteria suggested you had to have X-ray changes before you could diagnose someone, and late-stage X-ray changes. This led to a delay in diagnosis of 8 to 10 years. And this is just showing the sacroiliac joints, which you should see nice, clear black lines, but we don't. And it's all sort of smudgy and white stuff there, which is sacroiliitis. That may take a long time to occur. So the ASAS, which is an International Society on Spondyloarthropathy, came up with new criteria for the diagnosis. So one is that you can have X-ray which shows sacroiliitis, and then you have, I can't see this red dot very well, the list below on the right, or you have the genetic marker B27, and one of the others, including an MRI, which has been very helpful in being able to diagnose this disease. The problem is that we often have a very long wait, as many of you know, up to a year before we're able to get an MRI and confirm the diagnosis. More recently, working with the radiologist at the Richmond Road, we've been able to improve that to 3 or 4 months for most of our patients. So that the MRI is very important in being able to diagnose earlier. One of the interesting things that we learned at this meeting was that I told you about the HLA-B27 gene being positive, but if you looked at a whole population with all of that back pain, how do you, B27 is going to be in people who don't have the disease itself, because 10% of the population has it. Dr. Proton Raman, who's part of SPARC, is in St. John's, Newfoundland, and he runs a genomics lab. And they have developed a chip, which is where they put small sequences of genes that are associated with ankylosing spondylitis. And what he's hoping to do is that create this small chip that you would be able to take a saliva sample, so you could spit on this, and that it would be able to help even family doctors in their offices distinguish whether this was potentially you had ankylosing spondylitis or not. So that was really exciting to learn about, and so he was combining not just HLA-B27 but other genes associated with ankylosing spondylitis. So that would be very helpful in trying to find that needle in the haystack of patients who have inflammatory back pain and have them seen and diagnosed early. This is just an MRI, and you're looking, and the MRI is so that you're cutting across here, like you're cutting in sections across, so you're looking down. And this is the sacroiliac joint. This is the normal one. And I don't think it takes too much imagination to see that that one is abnormal or different on the other side. We talked about new bone formation. So first the sacroiliac joints are involved. And then in some patients, not all patients, it progresses to involve other parts of the spine and to cause fusion in the spine. And this is just showing the stages of it. So here's X-ray showing a little bit of new bone formation. And here's, you can see what's called a bamboo spine, where it's fused all along. And therefore you don't have motion. And this is an old picture that everyone has seen, is with ankylosing spondylitis over the decades, what can happen with fusion of the spine. So we actually have more information now on how we can on what's important in fusion. So not everybody fuses, only some people actually fuse, and why is that? This is just a slide that hasn't shown up very well to show that diagnosis is important, preventing bony changes is important, maintaining mobility is important, which allows you to be active. So back to progression. And why do some people fuse and others don't fuse? What has recently been found that smoking contributes significantly to the development of spinal fusion. And, And so you can see these are patients who didn't smoke versus those who smoked and having changes in their X-ray scores. And on this side, you can see the longer you've smoked, the worse the chances are that you're going to get the spinal fusion. So cigarette smoking is a problem for developing spinal fusion and ankylosing spondylitis. So not only does it interfere with your lungs, and your lungs may not expand as well, and there's all the other reasons you shouldn't smoke, that developing fusion of your spine when you smoke is really important. The other thing that has been found is that if you actually have developed bony changes already and you smoke, then your risk of developing that spinal fusion goes up significantly to about 40%. Whereas if you don't smoke and you have no changes, i.e. early disease, and you don't smoke, your chances of having that spinal fusion are only about 40%, so a tenfold increase. So catching it early is important, not smoking is important, and treating early is important. This is also work that was done by Nigel Haroun, who's part of SPARC, and for the first time showed that using anti-TNF agents that patients didn't progress with their spinal changes with the fusion of the spine. And remember, when you have X-ray changes, that leads to decreased mobility, leads to disability. What's important here, and this is why, you know, treating the right person, is that these people who, in the blue, are patients who who got biologic therapies late, and in the red, who got them early. But you can see that there's a group at the bottom that actually don't progress anyways. And then you have 60% that do progress, and you have a smaller percentage still who progress, only 20% who progress rapidly. So you think, you know, that 40% at the beginning, do we actually, you know, how do we need to be treating them? Do we need to be treating them differently because they're not going to progress anyways? Maybe we don't need to be as aggressive with therapy. And then that last group, the last 20%, maybe we have to be really aggressive. So how do we know who to treat when? And we don't. So basically, the study that Nigel Haroun and SpA did, first study to show that, that there is disease-modifying effect by using TNF and AS. Early use is more effective. Sustained treatment reduces progression. Smoking and baseline inflammation are risks for developing that fusion. And having that baseline damage at the beginning is a very strong predictor of having future changes. So this is just a little bit on treatment. So I want you to notice that this mainstay of treatment on the right-hand side is physical therapy, exercise, self-management. And yet it was pointed out at this meeting that a small portion of the budget is for physiotherapy or rehabilitation for patients. And I think you've all come across that, where you can't get access to physiotherapy unless you're paying out of your pocket or you have a private plan. And everything else is very limited. So this is across the country that this is an issue, and something that I think that perhaps with the CSA can address the lack of available resources, and where that is actually the mainstay of treatment for this disease. Anti-inflammatories, you know, your ibuprofen, your Motrin, your Naproxen, your Celebrex, etc., are useful in pain and movement. We learned also in the last 2 days that whether you take the anti-inflammatory continuously or you take it only as you need it does not change the progression of the disease. So you can take it as you need it if you're well in between. It's important to keep your pain under control so you move well. So if you have some swelling in your joints like your knuckles or wrist, sulfasalazine may be helpful. If it doesn't work, a local corticosteroid may be helpful, and then biologics. However, if you have axial disease, if your spine's involved, or if you have enthesitis where your Achilles tendon, etc., are involved, the drugs like sulfasalazine, methotrexate do not work. They do not help that at all. So therefore, if you have primary spinal disease or enthesitis, then the treatment is anti-inflammatories, physiotherapy, exercise. If that's not working, then it's the biologic therapies. So as we know, these new drugs have revolutionized the treatment, the anti-TNF therapies, the Enbrel, Humira, Remicade, but they have, there's still about 40% of patients who do not respond to those. And have, so that seeing a rheumatologist is really early. Early is important. So always people have to weigh the decision to go on these biologics or take medications. What's the risk of arthritis? How am I going to damage joints or not? How is it affecting my quality of life versus the benefits of treatment and the risk of treatment? And that's something you have to figure out in your own mind when we discuss things. And I'm really working with us and working with Carolyn and working with Alex, who's a physiotherapist, making those decisions. You know, is it the right time yet to do this? Knowing that they will work in 60% of patients, particularly the anti-TNF. So back to this picture, I want to talk about what's new. So for some reason, we do have drugs to IL-23. They are very effective in psoriasis, but they don't seem to be working in ankylosing spondylitis. So therefore, but we do know that TNF is very effective, and we know we have new drug called Cosentyx or secukinumab that inhibits IL-17, and it's very effective in ankylosing spondylitis. So it must be driven by another mechanism other than just with this mechanism with IL-23. So Stelara is a drug that's available with IL-23 that's effective in psoriasis, psoriatic arthritis, not effective in ankylosing spondylitis. So these are the current medications that are approved. The top 5 are all drugs, anti-TNF medications, so they inhibit tumor necrosis factor alpha, one of the pathways. As I said, only 60% of patients actually respond to these, and sometimes they lose the effect. That etanercept does not work for the uveitis, and so you can get progression uveitis. So if you had, and it doesn't work for inflammatory bowel disease, so if you have some of the comorbidities, you're not going to use etanercept. The others are pretty much similar. The secukinumab is also called Cosentyx, which is a newer medication that is effective for ankylosing spondylitis, and it works by a different mechanism of action, targeting what's called IL-17. Other trials that are going on, there are new small molecules that are coming out, so rather than an injection, they're pills, and they're called JAK inhibitors, and so there's some work suggesting that these JAK inhibitors, one that's available in the market, others that are coming onto market, that are very effective in ankylosing spondylitis. So there may be pills in the future that are effective for treating this disease. So what else can you do? Educate yourself, exercise, proper nutrition, manage pain and fatigue, work with your healthcare team, and stop smoking. Nutrition and nutrition supplements that really, and we'll probably get into this in some of the conversation, a good, healthy, balanced diet. Are there special diets? We don't know. The microbiome's important, but we don't know exactly what that is or what we need to be doing at this point. Pain, fatigue, that's really important that has to be addressed and managed, and our pharmacist, Alex, is going to talk about this. So, ankylosing spondylitis is a chronic disease. It's similar prevalence to rheumatoid. It's associated with this genetic marker, B27, but there are also other genetic markers that when combined, we may be able to diagnose people early, which is really important because we know if we diagnose early, treat early, we prevent disability. We have difficulty with diagnosing now, so magnetic resonance imaging does help us make earlier diagnosis. And non-steroidal anti-inflammatories are very effective for many people and are the first line with physiotherapy and exercise, which is crucial. And for those patients who don't respond to that, there are anti-TNF agents, there are now IL-17 agents, and it looks like there are going to be new drugs, which are JAK inhibitors as well, that would be effective. So, questions, I think, or yes? So it doesn't work on the spine, it doesn't work in the sacroiliac joints or where the tendon inserts. It does work in psoriasis, psoriatic arthritis. It does work if you have small joint involvement. So knuckles, wrists, elbows, toes, those sorts of things. But if it's strictly disease of the spine, that's where the problems are or where the tendons are. Oh, sorry. If it's strictly disease of the spine or where tendons insert, then it's not effective. So really what we know is how we should treat these diseases is you should treat what the biggest problem is. Right? If psoriasis is the greatest problem, that's what we should treat. If peripheral arthritis is the biggest problem, that's what we should treat. But if spinal disease is, then those medications are not going to be helpful. And anti-inflammatories. So, naproxen, Voltaren, all of those, if they are ineffective, then it is the next line of treatment is to go to the biologics, either inhibiting the anti-TNF, which is the usual ones here, newly inhibiting the IL-17, which is a new drug called secukinumab, and potentially in the future the other new ones, the JAK inhibitors. So I mean, it's exciting because there's lots of new treatments, lots of new things, lots of better understanding of the diseases. So I think we had lots of question time later.
Yeah, we're going to do the questions in a panel. So just a reminder, you have blue sheets if you want to put questions. Usually it's this point in the session that we start collecting these things, and we collect them, then I'll start grouping them so we can have common questions grouped. Hopefully everyone has the speakers' profiles. Is that a yes? I mean, worth your while to check this out. I mean, we have fantastic people here doing tons of work on our behalf in arthritis. So I won't go into all the introductions that you have them, but please look at them. So next person up, I believe, is Dr. Zuzina. I can give a little bit on you as the clinical assistant professor at University of Calgary. She did her residency in rheumatology at the University of Calgary and clinical research in psoriatic arthritis and lupus at Toronto Western. So thank you very much for being here.
Thank you for inviting.
This one? That's to advance the slide. That's a laser pointer. Don't push this button.
Okay. Good morning, everyone. Thank you for coming, and it's nice to see that so many people were able to make and find this place in time. So I'm going to speak about psoriatic arthritis, which is the second most common type of arthritis or diseases that fall under umbrella of spondyloarthritis. And it happened to be my particular clinical interest, or one of them. So psoriatic arthritis is, those are my financial disclosures, so I do consult and provide advices to different pharmaceutical companies. So psoriatic arthritis is the type of inflammatory arthritis which is associated with skin psoriasis. So skin psoriasis is the red scaly rash that usually occurs on the extensor surfaces of the elbows and knees, and it's pretty common. It affects anywhere between 1 to 5% of the population, depending on the ethnicity and geographic location. And it's estimated that 7.5 million of people in the United States have diagnosis of skin psoriasis. As I said, it affects all genders, ages, races, and ethnicities, but there is some variation in probably following the same pattern. The further is from the equator, the more prevalence of psoriasis you can find. It's not always a severe rash. Only 20% of the people have a very extensive disease. However, almost half of the people with psoriasis suffer from severe symptoms like itch. So psoriatic arthritis is the arthritis that is being associated or found with, in association with psoriasis. And it's estimated that between 10 to 40% of people having psoriasis will eventually develop psoriatic arthritis. So it's the same type of inflammation that is found in a skin that extends further out and starts involving underlying tissue such as tendons, ligaments, and joints. And therefore, disease can present in many different ways. So it can present as arthritis, which is a true inflammation of the joints. It can be enthesitis, which, as Dr. Mosher explained, is a site of insertion of the tendon into the joint, called enthesis. So enthesitis is the inflammation in that particular area. Dactylitis is the inflammation of the entire digit, toe or finger, and we always refer it as a sausage-looking toe or finger. And it also can affect the spine in the same way as ankylosing spondylitis done. So there is a big diversity of how psoriatic arthritis can present, and often it's not one particular type. A disease can evolve from one form to another form, and sometimes there is a different overlapping presentation of psoriatic arthritis. So on the picture you can see inflammation of the Achilles tendon, which is the enthesitis. You can see skin rash, nail disease, and inflammation in the fingers. So as I said, it affects both males and females equally, and incidence of psoriatic arthritis is continuous. Old teaching said, we used to say that people develop psoriatic arthritis within 10 years of diagnosis of psoriasis. But now we know that that incidence is continuous, approximately 3% per year, and that is not limited to first 10 years after diagnosis of the skin disease. So people never can say, you know, like, I will never develop psoriatic arthritis because I had psoriasis many years ago. They continue to carry risk of developing inflammation in their joints. Severity of the psoriasis is not predictive of severity of the psoriatic disease. But it is predictive of the occurrence of psoriatic arthritis. So the more severe your skin, the more chances that person will develop inflammation in the joints. But inflammation of the joints might not match the severity of inflammation in the skin. Another particular risk factor of developing psoriatic arthritis is obesity. And nobody really knows it, a chicken or egg phenomena. Obese people often don't exercise, don't move well, and that's the reason why they develop more, and they have more mechanical pressure on their joints, and is that a reason why they develop psoriatic arthritis? And on the other hand, psoriatic arthritis prevent them from moving well and exercising and keeping in shape, which contributes to obesity. So this slide shows that severity of psoriasis is predictive of your chances developing psoriatic arthritis. So we estimate severity of skin disease by the area of affected skin. And usually it's being counted as your palm. So your palm equals 1% of your total body surface area. So people who have very little or no psoriasis, chances of developing inflammation in the joints is very little, approximately 5%. But with increase in area affected by the skin inflammation, your chances of developing arthritis goes up in geometrical progression. So when there's more than 10 palms being affected, your chances of having inflammation in the joints going up to 60%. So most of the people develop skin inflammation first. And as I said, old teaching used to say, you know, it precedes the joint inflammation by 10 years. However, there is a small proportion of people that develop both diseases simultaneously, and sometimes in rare instances, people develop inflammation in the joints first and skin follows behind. Those patients sometimes are misdiagnosed, so they might carry a label of different type of arthritis, like rheumatoid arthritis or osteoarthritis, and only once they present with the typical skin inflammation, their diagnosis might be reconsidered. Despite of delay in diagnosis because of we often do not have the full picture at the time of the presentation. Most of the people have a very rapid progression of the joint damage. And some of those people have already present with the joint damage at the time when they see a physician for the first time. So 2/3 of the people have at least one erosion on X-ray at the time of the diagnosis. And if you look at the MRI, which is more sensitive method of assessing joint health and joint structure, up to 70% of people have MRI abnormalities at the time of the diagnosis. So early diagnosis is very important, and I think I'm just repeating the same message as Dr. Moshe tried to convey. So the early we're able to diagnose the disease, the earlier we can start treatment, appropriate treatment for the disease, the better chances people have of preserving their joint structure and avoiding deformities. So it's been estimated that after 10 years of the disease, almost 55% of the people will have 5 or more deformed joints. And even delay in diagnosis by 6 months results in a significant difference in the disease progression and damage of the joints. So this is a study from UK looking at the time of the diagnosis from the first clinical symptoms, and they divided people in those who were diagnosed within first 6 months and those who had delay, and found that people with delay in diagnosis had 5 times more chances of developing erosions and 10 times more chances of developing severe deforming form of arthritis. But all other outcomes such as functional status and effect on a spine were also significantly higher. So talking about clinical features of psoriatic arthritis. If you want to remember one thing about this particular disease, it would be that it can present in many different ways. It's a very heterogeneous disease. There are probably not 2 patients that present exactly in the same way. It's a very interesting disease, but at the same time very challenging to diagnose and treat it. So the disease can affect many domains or many clinical and have many different clinical features. So as we kind of used to associate arthritis with the inflammation of the joints, and that's the first picture on the top. That's how psoriatic arthritis can present. So it can affect small peripheral joints or large weight-bearing joints and cause deformity and loss of function in those joints. But disease also can present in the same way as ankylosing spondylitis presents, with inflammation in a spine. And it's, as Dr. Mosher mentioned, usually starts in the SI joints, but can progress along the entire spine, entire spinal column. Disease also can obviously have, people can have involvement of the joints, involvement of the skin, and involvement of the nails. It can present as enthesitis, and it can present as a dactylitis. So 50 years ago, when the disease was first described and kind of the term of psoriatic arthritis was established by the 2 grandfathers of this particular condition, Dr. Moll and Dr. Wright, they identify 5 particular subtypes or patterns of the disease. However, later on, we learned that those patterns are not always stay the same. So disease tend to evolve, and often people start with one particular type or pattern of the disease and end up in a different one and in a third one as time progresses. Therefore, now we try to stay away from this particular classification and rather talk about domains of the disease. And those, as I already mentioned, would be the 5 most common ones, as arthritis, enthesitis, spondyloarthritis, skin and nail, and dactylitis. So when we try to tailor our approach to management, we look not at which particular joints are involved, but more in terms of which domains of the body are being affected by the disease. If you try to look at the predictor features of how people who are going to develop the disease and how people are going to respond to treatment, we find some features that help to guide us. Those are the severity of the scalp psoriasis, nail psoriasis, psoriasis involving gluteal and perianal areas like folds, severity of the psoriasis, and Koebner's phenomena, which is the phenomena of developing psoriatic lesion and the areas of small injury on the skin. So all of those features seems to be associated or being predictive of development of psoriatic arthritis. There are also some environmental factors that we were able to identify that are linked to your chances of developing psoriatic arthritis. And those are heavy mechanical stress, such as lifting cumulative loads of more than 100 pounds per hour. So people who have heavy physical strenuous work, they're more predisposed to development of psoriatic arthritis. And that may be connected to our second factor, which such as injuries, which are not uncommon in people who are involved in a heavy physical work. Infectious, such as especially as a strep throat infection, seems to trigger onset of psoriatic arthritis, and there might be some overlapping themes with the fact of microbial role in pathogenesis of ankylosing spondylitis. So we know that microbes that live around us or inside of us are very important. And again, this is area of further research and investigations. We can appreciate some connections, but we still don't know the exact mechanism how is exposure to infectious or change in a combination of the microbes that we carry inside trigger the disease. And of course, smoking, again, I'm repeating the same themes as Dr. Mosher mentioned. Smoking is a risk factor for developing of psoriatic arthritis. The studies showed no connection to alcohol consumption, stressful light events, or fluctuation in hormonal levels to development of psoriatic arthritis. Although many of our patients associate the onset of their disease or flares of their disease to particular stressful situation in their life. Again, it's very hard event to measure, and maybe that's why we are not able scientifically to connect those two things. So psoriatic arthritis is a very interesting disease. It's a fascinating disease, not only because of its clinical presentation, but also of its pathogenesis. So most of the diseases or arthritis follow a particular type of joint effect, such as rheumatoid arthritis is an erosive disease. It causes bone loss, bone erosions, holes in the bone, loss of the bone structure. Ankylosing spondylitis, on the other hand, is the disease of extra bone formation. As Dr. Motion demonstrated, there is extra bone that is being laid out, and eventually it ossifies your entire spine and prevents spine from movement. So psoriatic arthritis is the disease that has features of both processes. And you can see those in joints that are one next to each other. So one joint on your finger can have extra bone formation, which we call periosteitis or ankylosis, and the finger next to it can have bone loss or osteolysis, like erosions and loss of the bone structure. Why it happens, we still don't know, and as I mentioned, that makes this disease particularly fascinating. Up to 40% of people with psoriatic arthritis can have spinal involvement, similar to ankylosing spondylitis, and we call it psoriatic spondyloarthritis. So it's the same type of process and same type of changes that you can see in ankylosing spondylitis. That's the extra formation. This is a very small pointer. But you can see on an X-ray of the sacroiliac joints, there is obliteration of the joint space. And in a spine, there is a formation of the bamboo spine with extra bone being laid out on both sides of the vertebral column, which forms almost like a extra layer of bone, and therefore really limits the mobility in a spine. We already mentioned enthesitis, which is a very clinically important feature of psoriatic arthritis. So it's the inflammation at the enthesis, and it sometimes also leads to some radiographic changes. So it's not only the inflammation, but inflammation can lead to the extra bone formation, such as erosions, or extra bone layout, such as spurs. So traditionally or historically, psoriatic arthritis was perceived or described as a mild form of arthritis. We used to say it's some old textbook were even describing this disease as a mild rheumatoid arthritis. However, we know that that's not true at all. So psoriatic arthritis could be as severe or sometimes even have more devastating than rheumatoid arthritis. And more than 50% of our patients have severe deforming erosive disease, and up to 20% of the people with psoriatic arthritis end up with significant disabilities. We already mentioned some comorbidities, and those are very prevalent in psoriatic arthritis. I'm going to show you data from Toronto cohort of a psoriatic arthritis clinic. So in yellow, it's a percentage of the people with psoriasis, and in blue with psoriatic arthritis that have comorbidities. So you can see that diagnoses such as hypertension, obesity, and dyslipidemia are very prevalent in both populations, and people with psoriatic arthritis affected more severely than those who have only skin involvement. People with psoriatic arthritis are predisposed to cardiovascular diseases and metabolic syndrome. Metabolic syndrome is a combination of conditions including high level of cholesterol, obesity, elevated blood pressure. Altogether, it's called metabolic syndrome. And each particular component of this syndrome is much more often found in people with psoriatic arthritis. Besides physical comorbidity, people with psoriatic arthritis have very often high psychological burden. We know that the prevalence of depression is very high in people with both psoriasis and psoriatic arthritis. People have poor self-esteem, often from very early age, probably due to their appearance and societal stigmata of having significant skin plaques and not able to socialize properly. It leads to poor self-esteem, sexual dysfunction, anxiety, depression, and sometimes suicidal ideation. All of those are significantly higher in people with psoriasis and psoriatic arthritis. And then social behavior cycle exacerbates the disease and comorbidities. As I mentioned, people who are ashamed or afraid to go to the gym or to exercise or to go and socialize have more rapid disease progression. So this is data from Swedish database. People with psoriatic arthritis were asked how their disease affects them psychologically. And you can see that more than 70% said that they have moderate or high impact, psychological impact of their disease. And only 30% mentioned that they have low impact. How do we treat psoriatic arthritis? So we, in the last 7-8 years, medical society has been developing a new approach to treatment of psoriatic arthritis called treat to target. In principle, it's the name of the strategy when clinicians treat patients very aggressively to reach and maintain certain clinical goal. And those goals could be different for different diseases. The whole concept came from the endocrinology, where physicians were trying to achieve certain level of the serum glucose. So there was a very easy target to identify. We know that maintaining a proper glucose level lowers your risk of developing complications of diabetes. So that concept being expanded in different areas of medicine, including rheumatology. So we decided that if we can identify a proper target in the treatment of arthritis, we can avoid long-term complications and disabilities. The problem is to identify a correct target. We don't have a particular number of the joint, that can truly represent the joint inflammation or the activity of disease in whole. But there was a new parameter developed called minimal disease activity. And as I mentioned, psoriatic arthritis is a very heterogeneous disease, so it includes many different domains of the body. Therefore, the minimal disease activity score had to include different parameters. And those would be number of swollen and tender joints, involvement of the skin, how big is the skin psoriasis, how bad is the patient global assessment of their general health, the patient assessment of their pain, patient assessment of their function, and number of inflamed enthesitis point. So there were 7 parameters, and if you have 5 of them less than 1, you reach minimal disease activity. So when we're treating psoriatic arthritis, that's what we're trying to choose as a target. So we're not only looking after the joints, we're looking also at the skin, we're looking at the enthesitis, we're looking at the patient level of pain and patient level of function. So how such heterogeneous diseases, psoriatic arthritis, is being treated? There is an international scientific group for treatment of psoriatic arthritis that issued its recommendation. So the recommendations are to treat the most affected domain of the body. So whatever bothers patient the most should be your primary, or should drive your therapeutic decision. So if it's the swollen joints, or it's the very bad skin, or it's the inflammation in the spine, is it inflammation of the entire digits, such as dactylitis, or it is an enthesitis. And we had to break it down in those 5 domains, or five therapeutic algorithms, because not all of the domains are responding to treatment in the same way. So such as peripheral arthritis is responding very well to anti-inflammatory medications at the mild stages, later to medications such as methotrexate, and only if you fail those 2 groups of medications, you can progress to biologics. Things like spondylitis, dactylitis, enthesitis, and skin often have shown no response to medications such as methotrexate. And therefore, we go from anti-inflammatory medications directly to the biologics. And of course, all of that has to be accompanied by things like physiotherapy, self-directed education, and a support group. So those are the list of agents that currently are being approved for treatment of psoriatic arthritis. And some of them came from our experience in rheumatoid arthritis. So the early ages, we borrowed drugs that shown to be effective for treatment of rheumatoid arthritis and tried them for treatment of psoriatic arthritis. But lately we found that those diseases are too far apart and sometimes are not governed by the same mechanisms. Therefore, in the last 5 to 7 years, new drugs for treatment of psoriatic arthritis actually come from dermatological experience. So medications that treat psoriasis well seems to work for psoriatic arthritis much better than those that treat rheumatoid arthritis. So far we have 5 anti-TNF agents, and those are exactly the same agents that are being approved for treatment of ankylosing spondylitis. And we have at least a decade of experience with those drugs. They work really well, but in the same way as in the arena of ankylosing spondylitis, we have only 60, maybe 70% of the patients that respond to those drugs. Therefore, there was a big need or niche that needs to be filled, and other drugs were developed. So we have IL-17 inhibitors, secukinumab or Cosentyx, that Dr. Mosher already mentioned, that's been approved already for treatment of psoriasis and psoriatic arthritis. And we have a second drug in the same class that is already approved for treatment of psoriasis and probably will be approved for treatment of psoriatic arthritis within next year. We also look at the different mechanism of action. We have one oral medication called apremilast, which is medication not as powerful as the biologics, injectable biologics, but is very effective and for some people and lacking major side effects, and another advantage that it's an oral medication. And we also have new mechanisms of actions that will be medications with new mechanisms of actions, which will enter our market pretty soon, or we hope that they will enter our market pretty soon. So those are the IL-23 inhibitors and JAK kinase inhibitors. So it's a very exciting time for physicians and patients with psoriatic arthritis. There is lots of research going on, and there is lots of drugs that are being in development and being through trials and show very promising results. And probably we're gonna expand our repertoire to, maybe even doubling the number of treatment options that we have right now, probably within the next 5 years. So we still have remaining challenges in treatment of this form of arthritis. One of them that its disease is very, very heterogeneous. So not all patients present in the same way, and not all patients respond to drugs in the same way. And sometimes treatment of one domain makes another domain worse. For example, we can have excellent response of the joints, but the skin flares up. So we're not treating one particular target. As I said, we have multiple targets that we want to address at the same time. Even our best medications so far show response of 50 to 60% in the first go. And once you fail first drug, your chances of responding to the next one go slightly down. So there's still a proportion of patients that we're not able to treat, to the minimal disease activity. Psoriatic arthritis historically used to be viewed as a mild form of arthritis, so there's not the same number of studies and monies and resources are being attributed to this particular area of rheumatology. However, this is is being, that attitude is being changed, so I think there is a particular interest to psoriatic arthritis in the last 5 years. And of course, we see multiple comorbidities associated with psoriatic arthritis that we also need to address and keep in mind. And obviously, we don't have a very specific markers or predictors for treatment and diagnosis of psoriatic arthritis. So sometimes we have to choose medications or treatments blindly, and therefore we not always pick the best medication on the first go. But those are our challenges, but also areas for potential research. Any questions? Do we have time for questions, or we'll just move on?
Yeah,
We'll do it later on. Okay.
We're going to try to pick up some time. Thank you very much. So we are going to do a break still, but we're going to do 10 minutes. Show of hands, who wants it now? Originally, we had one more presenter. Do you want to break now, or do we power through and do it after? Raise the hands for now. Okay, power in numbers. Let's break for 10 minutes. There's sandwiches and refreshments outside, and then I will start yelling in 9 minutes. This is a good time, actually, to pass your blue question sheets out there. You'll find me or some other members of our volunteer team.